endocarditis. So the endocarditis is basically the inflammation of endocardium, right? So heart has a
Yes.
three layers: epicardium, myocardium, and endocardium. So epicardium is outer layer of heart, right?
Yes.
So can anybody tell me the location of the coronary vessel? They are again high yield stuff. Where is the coronary vessel located? Coronary vessel, where the coronary vessel located?
Subendocardium.
Sorry? Subendocardium?
Subendocardium.
No, no, no.
No,
Subend
I think
Epi,
they are in
epicardium.
the
epicardium.
coronary.
In the epicardium or below the epicardium. So this is again a high yield point that you so so this is the coronary vessel. These are the coronary vessels, right?
Yes.
So the coronary vessel located below the epicardium. Okay. So this is myocardium. So myocardium is again the muscles of the heart. And endocardium contains valves of the heart. So today we will discuss the inflammation of this innermost layer of the heart, right? So this yellow shows, this one shows yellow epicardium. Epicardium is also known as a visceral pericardium. Which cardium? Visceral pericardium. And this one, this layer is parietal pericardium. Which cardium?
Parietal.
Parietal pericardium. And this is one fibrous pericardium. Fibrous pericardium, right? So
Yes.
pericardium has three layers. This is again an important stuff. So pericardium is three layers. So the outermost is fibrous pericardium. This outermost layer is fibrous pericardium. Then this one is parietal pericardium, and this one is visceral pericardium. Pericardial space is where is the pericardial space? Pericardial space. Can anybody tell me in which layer? In between which layer? Pericardial space.
Yeah. That would be between the parietal and the visceral.
Yes, this is in between parietal and visceral,
Yes.
right?
Yes.
So the
Yes.
inflammation of the pericardium is called pericarditis. We will discuss pericarditis in detail. So this is again important topic. So the inflammation of the pericarditis, also inflammation of the pericardium is known as pericarditis, right?
Yes.
Okay. So can anybody tell me what is the most common cause of the pericarditis?
Viral infection.
Yes.
Idiopathic. Idiopathic.
Idiopathic.
After idiopathic, then it is viral, right?
Yes.
So this is the middle layer is myocardium. So inflammation of the myocardium is known as myocarditis, right? So can anybody
Yes.
tell me the most common cause of the myocarditis? It is viral. Okay. So next is endocardium. So endocardium, inflammation of endocardium is known as endocarditis. Endocarditis. What is the most common cause of endocarditis? What is the most common
Pneumatic
cause of
heart.
Sorry?
What in called disease?
Bacteria, right?
Yes.
Yeah.
Bacterial endocarditis is the most common endocarditis, right?
Yes.
So, endocardium contain valves, right?
Yes.
So anything. So and this endocardium, this endocardium is lined by endothelial cells. So what happen? The foreign particle, bacteria, or any other thing damage these, result to the injury of this endothelial cell. So injury, this let's suppose the bacteria. This injury lead to the formation of vegetation. So it is a very important. Vegetation is consist of which of the following things? So vegetation is consist of platelets, fibrin, and microbial products. And microbes are microbial products. So these are main three components of vegetation. This vegetation is the culprit of the pathophysiology of the endocarditis. So this may lead to the valvular dysfunction, valvular dysfunction, right? This may lead to septic embolism. So this is septic embolism, right? We will discuss the septic embolism in detail. So septic embolism. So vegetation increase the risk of the septic embolism and valvular, and it also lead to the valvular dysfunction. Okay. So what is a septic emboli? The septic emboli is basically this vegetation may dislodge in any vessels and block this vessel and may lead to the infarct of that area that is supplied by that vessel. So this is right atrium. This is left right ventricle, and this is left atrium, and this is left ventricle. So right-sided emboli, right-sided. This is right-sided. Right-sided emboli lead to the pulmonary infarct or pulmonary emboli. Right,
Yes.
right-sided, because right-sided blood goes to lungs. So it will lead to the pulmonary emboli, right?
Yes.
And this is left side. So left-sided septic emboli lead to systemic emboli. I hope it makes some sense.
Yeah.
Yes.
Systemic emboli, because the left-sided blood goes to the systemic vessels, right?
Yes. Yes.
So why I'm focusing on this thing? So you found a lot of questions on this kind of the emboli because they give you the history, sudden history. So the most common presentation of endocarditis is, what is the most common presentation of endocarditis is? Fever.
Fever.
When we
Fever.
say that endocarditis, it is, we will commonly said it's a bacterial endocarditis, right? So
Yes. Yes.
because bacterial endocarditis is the most common cause of endocarditis. So it is most common presentation is fever. After the fever, then new onset murmur, right?
Yes.
Yes.
So these are key things that show that type. One more important thing, we will discuss these things in few minutes. Okay. So keep in mind emboli and why it is important in USMLE, emboli, because it's clinical manifestation. Okay, so in endocarditis divided into, it is my, it's divided in many ways, but so it may be divided into the bacterial endocarditis, fungal, non-bacterial, or non-infective. We will discuss this. This is rare and this is most common. Okay, so bacterial endocarditis further divided into the two types, acute and subacute. What is the most common organism that is associated with acute bacterial endocarditis?
Staphylococcus
Staph
aureus.
aureus.
Staph aureus, right?
Yes.
Yes.
So it is high virulence organism or less virulence organism?
High virulence.
It's high.
High virulence. What is the most common predisposing factor for the Staph aureus?
Like IV drug use.
IV drug abusers, right?
Yes.
Okay.
And also
IV drug abuser. And which valve is affected by IV drug abuser? This is
tricuspid.
so high yield. IV drug abuser,
Tricuspid.
tricuspid. So why it is
Yeah.
tricuspid? Because you inject something in the vein and then blood goes into the vein from the right atrium and then the left right atrium to the vena cava and then the right ventricle. So first valve that is encountered by the blood is tricuspid valve. That's why the tricuspid valve is most commonly affected in IV drug abuser. And most common organism is Staph aureus. And it is acute. Why it is acute? Because it is short ST. Days to, this is again a key thing. Days to week. You have to differentiate between acute and subacute bacterial endocarditis. So it is days to week, right? Staph aureus, high virulence. Okay, so IV drug abuser, basically the injected particle damage these valves, tricuspid valve, right? So this micro damage facilitate the bacterial attachment. So you inject something in the vein and the injected particle damage the tricuspid valve and this damage valve facilitate the bacterial attachment. Okay.
Yes.
Can you tell me the any infection that also increase the risk of Staph aureus? Any infection that predisposed to IV drug abuse, infection, and Staph aureus?
I'm not understanding the question.
Okay, so IV drug abusers are associated with HIV. So HIV is strongly associated with IV drug abusers, right? So
Okay.
HIV patient has an increased risk of Staph aureus acute endocarditis, right?
Yes.
So HIV increase the risk of the acute bacterial endocarditis, right?
Yes.
Yeah.
Okay, so the tricuspid valve is affected. It will increase the risk of the systemic emboli or pulmonary emboli.
Pulmonary.
Yes, it will increase the risk of the pulmonary emboli. right? Does it make
Yes.
some sense?
Yes.
Okay. So sometime we will discuss if the left-sided, which valve is the most commonly affected in bacterial endocarditis. Which valve is most commonly affected? It is a mitral valve, right?
Microbiome. Yes.
Mitral valve. Okay. So it is a left-sided pathology. So it will increase the risk of systemic emboli. So systemic emboli patient present with fever, short history of the fever, plus new onset, murmur, plus weakness, sudden onset of the weakness or paralysis. So this is a very high yield. And how will you treat that patient? Sometimes they give you these kind of the clinical vignettes and they ask you, how can you treat this patient? What is your treatment in this case? Patient has a
Blood culture
sorry.
and they treat. We do blood culture and then give antibiotic according to the blood culture.
Okay. So the fever new onset. So first we do First we do blood culture, right? Okay. So blood culture will show that which organism, right?
Yes.
So if it is an acute bacterial antibacterial endocarditis, can you tell me which empiric antibiotic should be used? This is again a high yield stuff. Empiric antibiotic that you will give before the blood culture. In acute bacterial
I think
endocarditis,
Amoxicillin,
we can use like what? Ceftriaxone?
no, vancomycin.
Vancomycin. Oh, yes, yes.
So acute bacterial endocarditis, the empiric antibiotic is vancomycin. So sometimes they ask about the mechanism of action of that antibiotic. Can anybody tell me the mechanism of action? The vancomycin. So question is a multi-layered. They give you the clinical vignette. They doesn't give you the diagnosis. You have to diagnose and you have to give the mechanism of action of that antibiotic. So vancomycin is
Yeah, it binds the G-ala portion of the cell wall.
okay. They are protein synthesis inhibitor, cell wall, any which kind of antibiotic is? It is cell wall synthesis inhibitor, right? You are right. You are right. You are right. Sometimes they give you the journal terms. So the words of the answers are very important, right? So,
Yes.
so vancomycin, right? Okay. So the fungal, can anybody tell me the any fungus that lead to the endocarditis?
Yes, Candida.
Candida. Which are the risk factors?
Candida, a person who is immunocompromised.
Yes. So the question is immunocompromised. Any other? Prolonged antibiotic use. Immunocompromised and prolonged antibiotic use. Okay, and the organism is Candida. So we will discuss the non-bacterial Non-bacterial endocarditis. It is a special name, non-bacterial thrombotic endocarditis. Right? We will discuss these. I made another slide for that, for non-bacterial endocarditis. Right?
Yes.
Okay. Okay. So this is the very high yield slide. So this one. So the gram-positive bacteria that involve in the bacterial endocarditis, right? So
Yes.
gram-positive, this is gram-positive, this is gram-positive. So it divide into the bacilli, foci, and branching filament. So I am talking about the only microorganism, only bacteria that lead to bacterial endocarditis. I am not going to detail in the gram-positive bacteria. We will discuss these bacteria in detail. Okay. So foci will divide into the step or Staphylococcus. If it is catalase negative, it is Streptococcus, and it will form pairs or chains. And if it is catalase positive, it forms clusters, and it is Staphylococcus. Right? So these kind of stuff. Sometimes they give the catalase positive. Catalase positive means Staphylococcus. Catalase negative means cocci. Catalase negative means Streptococcus, and it will live in pairs or chains. So Staphylococcus further divide into the Staph aureus. Staph aureus is associated with tricuspid valve, right?
Yes.
IV drug abusers. Okay. So it is coagulase positive. Sometimes they give you this kind of the thing. They give you the clinical winner and they give you the options like if a cocci, catalase positive, negative, these kind of the stuff, right?
Yes.
And you have to identify that bacteria or microorganism that is culprit for that pathology. Okay. So novobiastin sensitivity. So the novobiastin sensitivity, if it is positive, it is Staphylococcus epidermidis. So Staphylococcus epidermidis is associated with prosthetic
valve.
prostatic
Well,
valve, right?
yes.
Okay. So Staphylococcus epidermidis novobiastin sensitivity positive, and it is coagulase negative, right? Okay, let's move towards the Streptococcus. So Streptococcus is further divided into the three types: alpha, beta, and gamma hemolysis. So alpha hemolysis means partial hemolysis, right? So
Yes.
alpha hemolytic bacteria divided into Step Nemo. If it is optogen sensitivity and bile solubility, positive. And if it is negative, it's a viridin
Evidence.
streptococci. So this viridin streptococci is a very, very high yield. Why it is very high yield? Because it is a culprit of subacute bacterial endocarditis.
Fever.
Subacute bacterial
Endocarditis.
infective endocarditis. Okay. So sometimes they love to ask, what is the thing that lead to this pathology? So this viridin streptococci mutants and mitins has special things that is known as limit dextrin. Limit dextrin. So this limit dextrin is carbohydrate. So that helps to attach with cardiac valves. So very high yield stuff, very, very high yield stuff. So this viridin streptococci has limit dextrin, right? The
Yes.
limit dextrin, that is a carbohydrate, is responsible for this infective endocarditis. Infective endocarditis commonly mean that bacterial endocarditis, right? Okay. So this is very important in case of bacterial endocarditis. Next more important thing is gamma hemolytic bacteria. So gamma hemolytic bacteria is divided into the further two types, Enterococcus and non-Enterococcus. So Enterococcus bacteria are lead to infective endocarditis in the patient who goes who from the GI or genitourinary procedure, right? So they give you they give you the history of the fever, new onset environment, and the key points. These are the key points, right? GI procedure and genitourinary procedure, right? GI procedure sometimes give you the history of the endoscopy, right? And genitourinary they give you the history of the cystoscopy. Cystoscopy. So you keep in mind which organism is responsible, Enterococcus, right? Okay. The next, again, the high yield stuff, the Staphylococcus. What is another name of this microorganism? Staphylococcus. S.
Bovis.
bovis. And it is associated with
Colon cancer.
colon cancer. They give you the in the clinical minute history of the colon cancer and inflammatory bowel disease, right? Colon cancer and inflammatory bowel disease, right? Okay. So these are the some
Yes.
high yield gram positive bacteria that are associated with infective endocarditis, right?
Yes.
Okay. Wait a minute, I am going to change my slide. Just a minute.
Can I ask one? Agalactiaceae is UTI, no?
Sorry?
Agalactiaceae is UTI, isn't it?
No, it's associated with the colon cancer and inflammatory bowel disease.
Agalactiaceae. I'm talking. Ask Agalactiaceae.
Sorry, what are you saying? I didn't understand.
I was just asking about Agalactiaceae. I just.
Oh,
I am asking about colon cancer and
Okay. Bovis.
bovis. You are
Sorry. Thank you.
got it wrong. You got it wrong. Okay,
Thank
just
you.
give a minute. I'm finding the slide again. Just a minute. Is my screen is again visible or not?
not yet.
Just give me 1 minute. Still
No,
not
no, still
visible?
not yet.
Okay.
Now it's coming. Okay, it's here now.
Okay. So we discussed some of the gram positive already, right? These kind of
Yes.
gram positive and their associations. To HACEK organisms are gram negative bacteria. The most important one is Echinella, right?
Yes.
Most important one is Echinella. So Echinella is associated with Echinella is associated with human bite, right?
Right.
So HACEK organism, in case of the infective endocarditis, they are not high yield. So the culture negative endocarditis, Coxella. Coxella is associated with Coxella is
Big
associated.
cattle and
Sorry?
Q cattle something and Q fever or something. I'm not sure.
What?
Okay.
This one
Rock,
associated with Q fever.
Yeah.
Rock, can you tell me
Yeah.
which fever?
Yeah. Q fever. Q fever.
Okay, what is a Q fever?
Um.
Q fever is from
Very good.
cattle dander or something.
Sorry?
As to is associated with like cattle,
What?
like
Okay.
in inhaling cattle danders and stuff.
Okay. Q fever is basically pneumonia plus hepatitis, right? Plus fever. And last one is non-culture infective endocarditis, right? So this is a Q fever. It is caused by Coxella. Coxella is zoonotic bacteria. Zoonotic bacteria. What is a zoonotic bacteria? That is
Bacterial.
bacteria that transmitted through another animal, right?
Yes. Yes.
Can anybody tell me the Bartonella? Bartonella is associated with
I think cats.
cat scratch disease. And these injection drug use, Staph aureus, Pseudomonas. Pseudomonas is gram negative. Candida, we already discussed, right? Okay, we will take, before discussing the presentation of infective endocarditis, one more thing related to Staph aureus, right?
Right.
So it may be MRSA and it may be methylene sensitive Staph aureus, MSSA and MRSA. What is treatment of MRSA is? Which antibiotic?
Vancomycin.
Vancomycin. So this is again a high yield point, vancomycin. And what is treatment of MSSA? Beta lactam. Most appropriate. If beta lactam is not present, then nephicillin, right?
Yes.
You found these kind of the stuff in the urine, right?
Yeah. You give staff to NAF. I mean NAF to staff.
Sorry, what are you saying? I didn't understand.
No, I was saying something. Yeah, you give NAF to staff.
Nephicillin. That is the penicillin.
Okay.
Okay, the first one is beta lactam. Beta lactam. Beta lactam, galvanic acid, selbactam, albactam, these kind of the antibiotics, right?
Yes.
So the presentation of infective endocarditis, we already discussed. The most common presentation is fever. After the fever, the new murmur. And then the symptoms are divided into the two things. The vascular phenomena or vascular problem. And another is immunological problem or immunological phenomena. Vascular phenomena is vascular problem are septic embolism, right? Septic embolism. So this is splinter hemorrhage. The picture shows a splinter hemorrhage and Janeway lesion. What is a Janeway lesion? What is a Janeway lesion? Janeway
Septic
lesion.
embolization.
Okay. So Janeway lesion are present in the which area of the body? Palms and soles. Palms and soles. They are painful. They are painful or painless? They are painful. They are
painless.
so they are painless. They are painless flat erythematous lesion present on the palms and soles. Right? Okay. So this is vascular phenomena or vascular problems. Now we're moving toward the immunological. So immunological, the most important is glomerulonephritis. Okay. So Osler nodes. Osler nodes. What are Osler nodes? Osler nodes are painful or painless.
Painful under the nail.
So they are painful, present on the finger and toes. Right? So this is Osler node. Right? So sometimes they give you the picture of the Osler node and they want to ask about it is which kind of the phenomena. So it is due to the immune complex deposition, immunological phenomena. So the mechanism of this Osler node is immunologic, not a vascular. So vascular is Janeway lesion, right? And this one is Roth spot. So this is Roth spot. Roth spot are basically the retinal hemorrhages. These are retinal hemorrhages, Roth spots, and there is a pale center. This one is pale center, right? So this is Roth spot, right? Okay. Give me a minute. I am going to change the slide again. The known bacterial thrombotic endocarditis. What about my screen? Visible or not?
Not yet.
Not yet.
Yeah, it's coming.
Now it is visible.
Okay. So this is non-bacterial thrombotic endocarditis. So this is the last slide of today's session. So the non-bacterial thrombotic endocarditis, it is mainly due to the SLE. It is mainly due to the SLE. So SLE, if it is due to the SLE, it is also known as Libman sake endocarditis. Libman sake endocarditis. Right? And if it is due to the malignancy, so most common due to the miscellaneous endocarcinoma of the pancreas, right? So what does these conditions do? These are the hypercoagulable states. So these are hypercoagulable states. So hypercoagulable state activate inflammatory cytokines. Increase inflammatory cytokines. and this cytokine lead to the deposition of material on valve. Deposition. What is another name of non-bacterial thrombotic endocarditis? Can anybody tell what is another name of the non-bacterial endocarditis?
Lickman sac endocarditis.
Sorry?
No, sorry. Marantic endocarditis.
Merantic endocarditis. Absolutely right. How they come in the exam? Right? So first they give you the clinical vignette, right? The clinical vignette. Then they give you the key points. You have to identify the bug, right? If they say that dental procedure, what will come in your mind? Dental procedure in the history. Which microorganism?
Subacute
Viridans.
Viridins.
Viridans, right? So this kind of stuff. So dental procedure, they ask about the mechanism of this organism, how they lead to this pathology. So how the viridans lead to the infective endocarditis?
Subacute.
Subacute. Limit dextrin, right? So the limit dextrin is a carbohydrate that is a culprit, right? Sometimes they give you the history of the IBD. The clinical vignette generally remains same, but IBD history suggests you which microorganism? Inflammatory bowel disease.
Bovis.
Bovis or colon cancer, right? These you have to aware about these key things. And sometimes the acute presentation, how will you differentiate from the acute and subacute on the duration of the presentation, right? Subacute weeks to months. Due to low virulence organism. And acute is due to days to week and high virulence organism. What is the clinical criteria that is used for the diagnosis of infective endocarditis? Hello?
Yeah.
Okay.
Hello.
What is the most?
It's called Jones. No, sorry.
No, it's a modified Duke criteria. Modified Duke. Right? So it is a modified Duke criteria. I'm not going to discuss the detail. So we will. These are the concern of the Duke criteria, major and minor. The mainly discussed in the step 2 CKIC, right? So you know that the Duke criteria. So the Duke criteria, major criteria is basically the positive blood culture plus vegetations on echocardiograph. So minors are another. So I'm not going to the diagnosis point of view of the infective endocarditis. Okay, the last thing. What is the most common predisposing condition for native valve infective endocarditis? native
Would that be
valve infective endocarditis. Mitral valve prolapse with regurgitation. MVP with regurgitation is most common predisposing condition that lead to the native valve infective endocarditis. Right?
Yes.
So these kind of the stuff and the systemic emboli present with symptom of stroke, right?